So, like I said, so EMTALA being a pretty big regulation, a big change, that was huge for us. It totally changed the way we did medicine. And now you're looking at not only all these people that now are going to have insurance that didn't in the past, but there's a lot of other regulations that are coming out of this. There's a ton of changes in the way that will be reimbursed. So currently, emergency rooms are reimbursed on sort of a sliding scale, if you will, like a level 1 to 5. 1 being you kind of came in with a cough and cold. We really didn't do much but write you a prescription. You're going to get the basic charge, which of course ranges from anywhere from $100 to $2,000 depending on where you are in the country. All the way up to level 5, meaning you had like a full workup, maybe you were probably in admission, maybe you went to the ICU, like so we have this range, and just that charge can be $5,000 or $6,000 just from that. And then of course we charge you for everything we've done to you as well, all the blood work and the IVs and all that kind of stuff. But CMS wants to now lump it and say, you know, we're just going to split it down the middle. So instead of allowing emergency rooms to sort of bill based on the level of services you received, we're just going to say, just call it even, everybody gets charged $300. So huge change. How will that change things for us? I would suspect it's possible that you'll see more people coming to the emergency rooms because there won't be as much out of pocket for them. So think about that. I mean, that's the other thing. I don't know if any of you had the opportunity to kind of look at the calculator for the exchange and just kind of see, gee, how much, if I had to pay for my health insurance, how much would it be? So I did that before it went live, just poke around. And then you look at the level of coverage and you realize, okay, great, so I'm paying a couple $100 a month for health insurance. This is good. But if I have to go to the ER, I have a $15,000 deductible. So that first $15,000 is coming out of my pocket. So, you know, and that's like maybe at the bronze level or whatever. So now you realize that's kind of cutting that pay scale down. Instead of anywhere from $90 to $5,000 just for the service. Now you're talking about everybody just being charged $300. Well, that's not so bad for the people in the middle. The cough and colds are sort of getting the bad end of the deal, but the people who are really sick get a good end of the deal. So it's really interesting that I'm not sure how that's going to really change it. If that even goes into effect, we don't even know because there's a lot of unknowns right now. So that's going to be, I think we'll see a lot of last minute sort of moving around, trying to figure out how are we going to still make money in this new model. The other thing that we have to do is do a lot more publicly reporting. So April, you mentioned throughput. Some of the things I have to report to CMS is from the arrival time. So the minute the patient walks through the door and presents themselves as an emergency room patient and says, I need to be seen, to the time that they're seen by a provider. I have to report that, and that's public. The goal is 30 minutes or less, but you guys saw in the movie, like that's just not possible for some ERs most of the time, if ever. So, and then like the throughput times, I have to report from the time of arrival to the time you got admitted. If you were an admitted patient, time of arrival to the time when you were discharged. So there's a ton of publicly reported quality data. Did you get your antibiotics, the right antibiotics within 60 minutes of arrival if you had pneumonia? So there's all this stuff that and you can go on to Hospital Compare, .org, I think it is, Hospital Compare, and just kind of look up, well, how is Sequoia doing? How is Stanford doing? How's this hospital doing? And it's one of those things that I actually tell people, you should probably have an idea of how your local hospitals are doing before you go in. Of course, you're all young and you never think that anything's going to go wrong, but someday when you have kids and stuff, those are the things that you'll start thinking about is, where do I want to take my child if they're sick or injured? You know, where do I want to take my husband if something were to happen? That kind of thing. Like, who's got the best cardiac care? Who's got the best neuro care? And as more and more of this information is made public, people really will be making their decisions much more based on true to life data and how the hospitals are responding and actually caring for their patients, because it's going to be right there. I mean, tons of quality metrics that we report all the time about how we're doing on all of our surgeries, on heart attack care, on congestive heart failure care, how we're doing on readmissions. So you come in for Congestive heart failure happens to be one of them. And are you readmitted back to our hospital in 30 days? So even if that's completely on you because you didn't take any of your medications and you ate the complete wrong diet, that's a ding on the hospital. So of course hospitals are now going, well, how are we going to make that work? Well, maybe we need to make some discharge phone calls and follow up and make sure they are taking their medications. If they're not, why not? So it kind of spurs on a lot more cost for the hospitals up front initially, but it saves us a lot in the end. So that's how every day, we're changing, we're always strategizing. How are we gonna get all of the dollars that we should be getting from CMS and from Blue Cross and Blue Shield and all of that? How are we going to get those dollars? Because if we don't meet these certain quality metrics, we're not getting them. So that's that whole compensation part that I was talking about. So that really has us all scrambling as we're learning new things. I can't tell you how many meetings we all went into about the 2 midnight rule. Well, how does that affect us? The 2 midnight rule, what does it even mean? I had to read it like 3 times before I understood, oh, okay, I get what they're saying now. The difference between observation and inpatient, how you have to have all this special criteria now for that. So it's really gonna be fascinating. I wish we were a little further along in the life of it, like a year or 2 down, I could really say the impact of it, but we don't know because every day we're even just getting interpretations from CMS. So they make these regulations and sometimes they don't even know what they mean by them. And then they release these, interpretations. They go, well, this is what we really meant. We go, oh, okay, now we'll go down that path. We'll go in that direction. So more to come on that, I guess. I wanted to get to some of your questions though, but I thought I'd just stop there and say, did anyone have any questions thus far based on what I've talked about? Yeah.
What was the 2 midnight rule?
So the 2 midnight rule, we have a difference between observation and inpatient. So you have to meet kind of higher criteria to be considered an inpatient in a hospital. But you can come in as an observation patient, which is really kind of technically an outpatient. And we get paid a little bit different that way. And what they're saying is, what was happening was patients were sort of languishing in this observation status and the billing was getting mucky. And CMS just said, you know what? We're going to make this a little more clear. After the 2nd midnight that you're in the hospital, you either have to make a decision and they better meet inpatient criteria, or you better get them out. Because what happens is, 3-4 days in observation. No, the point of observation is you're supposed to get them in and get them out, figure out what's wrong with them, fix them, and send them home, because they weren't sick enough to be an inpatient, but not really well enough to go home. So that now they're saying you can't let them languish, for 3 or 4 days. What we're saying is if you get admitted at 11 o'clock tonight, at midnight, that's your first midnight. Now you have basically until tomorrow night at midnight to either get that patient well enough to go home or someplace else, set up all the stuff, maybe home care or whatever they might need, or they better meet inpatient criteria, because after that, we're not paying you for any more time. So again, another one of those things that's like, whoa, how are we going to make that happen? Because sometimes people, they get admitted at 11 o'clock at night. Now I've got to wait for an echocardiogram of the heart, but the echo department is backed up, so they're not going to be able to do that until 5, 6 o'clock tomorrow night. Then the doctor's got to read it, and now you're like, okay, now there's nobody around to get the patient out, because you know what, they're kind of a little too weak to get up the stairs, and social services said you really probably shouldn't send them home, but they don't meet inpatient criteria, so there's a lot of like scrambling and changing the way we provide services because of that.
And Eleanor, because this was something that I was involved in somewhat at Square. So, and from a nursing perspective, what I heard from a lot of nurses on the floor, right? So these are patients that, come into the ER and the ER physician, decides like, listen, I need to admit them, and is involved probably in the decision about that their observation.
Yes.
Right? But then they get up to this floor, this maybe medical surgical unit probably, and from a nursing perspective, the nurses aren't treating these patients any different, right?
No.
I mean, a patient is a patient. You're just taking care of them.
Right.
Yet there's this, there needs to be this urgency around figuring out kind of what's going on, and the care might look a little different.
Right.
But nurses, I think that's very hard. Right?
It is. It's very hard. And so a lot of, I don't want to say a lot, but some hospitals are kind of making observation units. So because you don't have to meet all of the regulations of an inpatient like you do for an observation patient. So they're like cutting down the inpatient admission paperwork, so to speak. Most of it's electronic now, but all of that the nurse would have to do initially. The other thing that some hospitals are doing, which is a really great idea, is they're creating these observation units that are kind of like right by the ER. They're typically run by either emergency room physicians or hospitalists, which are physicians that work for the hospital. Most physicians that come in and see patients in hospitals don't work for the hospital, unless you're in Kaiser. So they actually come in and they have like a really set criteria. Okay, so you're here with a chest pain, rule out MI, heart attack, right? That's what you're here for. Boom, boom, boom. We're going to do these 3 things. We've got to get your serial enzymes. And you have these nurses and doctors that just sort of have these pathways that they're going to follow. And unless something drastic comes out of the tests that they're doing for you, they already know the plan for you, because you came in with chest pain and we're ruling out a heart attack. So we already know what these things we're going to do, and we're getting you out by 10 o'clock tomorrow morning. So they've really created this really well-oiled machine. We know we don't have to ask you 8 million questions like we do when you're a normal inpatient, so the paperwork is 2 pages instead of 16. And nurses are, kind of training just to be in this really quick turn and burn, we'll get you in and out kind of environment. It's almost like, a little bit like an ER environment in a sense, because there's always something to do for these patients. There's not a lot of sitting around, watching TV. We're getting you to test. We're doing what you have to do. The different hospitals, there's a lot about these observation units. So everyone's kind of weighing that right now. Is that something that we want to do? Any other questions on that?
We're talking about hallway chairs and strips.
Oh.
How do you deal with HIPAA?
Yeah, carefully.
I think maybe not everybody knows what
Okay, yeah, so HIPAA is like the Privacy Act. It's a lot more than that, but basically it says that, so as an example, if I accidentally faxed April's medical records after she came into the emergency room to the guy down the street and not the doctor because I mixed up the numbers on the fax machine, I've now violated HIPAA and I have to self-report. And I have to let the state know that, and April, I'm so sorry I've let your whatever it was, and Mrs. Jones got it, but as soon as she got it and realized it was wrong, she ripped it up. So that's like, we have all these privacy rules that we have to. And so you have to be really careful, because I can't just sit there and say to April, oh, you know your neighbor, Mrs. Jones. She was in the ER yesterday. You wouldn't believe what she did, She fell and she did. I can't say any of that to her. I couldn't say that to her if it was her own mother that came in the emergency room. I'd have to make sure it was okay with her mother that I had that conversation with her. So there's a lot of privacy rules. And so that being said, you can violate HIPAA by 2 nurses or standing in an elevator talking about a patient that they're both caring for, and there's a visitor there. So that's kind of that question about, well, when you're in a hallway or you're out in the chairs in the waiting room, how do you deal with that? So they kind of give you a little bit of a pass from a standpoint of if you're making a reasonable effort not to let the world know, everyone else know what's going on with this patient, you're making a reasonable effort, because they recognize a lot of emergency rooms, a lot of hospitals, they don't have private rooms. And so, the guy next door in the bed next to you might be hearing all about what's going on with you. And you just have to make a reasonable effort to close the curtains, speak softly. If I walk into the room and let's say April were the patient and people were there, I would say, April, I have some questions to ask you. Can these people stay? Or, you just have to make a reasonable effort. Privacy in general becomes a problem. You have somebody in the hallway with chest pain because you have no monitored beds yet that left. So first of all, that's dangerous because you can't see their rhythm, so that makes you nervous as a nurse. And you've got to do an EKG on them like right away, because you have to see if this is something we've got to take care of right away. And so now you're trying to do an EKG on a little different for a guy. It's not as embarrassing to expose your chest, but for women, we've got to put all these leads on underneath and do all this stuff. So we do a lot of care in the hallways, and privacy is from a medical privacy standpoint and just general privacy and decency. Nobody wants, you're sick, you don't feel good, you're laying in a hall, it's noisy, it's never a good situation, but it's very real. Any other questions on that? Yeah.
You mentioned observation units. You mentioned there's like a checklist of things basically that the physician who's attending would have to go through. Wouldn't that sort of leave like a doorway open for some more minor illness that would basically go undiagnosed, so that might recur as a big issue later on?
So they do, of course, like a full history and physical. So something could come up. But you're right, that's always, even in an inpatient situation, there's always the possibility that we didn't cover that base for you. Hopefully that will come out in your history and physical, but here's a great example of that. We'll get this a lot of times after surgery. So, you can't eat or drink anything like after midnight for surgery the next day. And you've done, as a physician, you've done your history and physical, you asked them about the medications they're on, you hopefully have them all. You hopefully know, you want them to stop taking their medications too, unless there's certain medications, and so hopefully they've given you all that information. But you know what people don't tell you a lot about? How much they drink. So now they've had a surgery, they haven't eaten anything, they haven't had a drink, and then they come out of surgery and they didn't do as well as you thought, so they decide, you know what, we're probably gonna end up keeping you 2 or 3 days. Now all of a sudden, what comes out? What is this other medical condition that comes out? The delirium tremors, DTs, withdrawal from alcohol. And so you're right, there's some things that we will not see. They may manifest themselves while you're in the hospital or not. Typically though, a good history and physical and an honest patient, you'll pretty much get most of it. Yeah, and we do some basic blood work on those kinds of patients anyway, so you're hopefully gonna catch things. But that's a good question. Yeah, Anthony.
You mentioned like quick patient turnover, like turnover during first.
Yeah.
So does that mean more efficiency on the hospital's part, or does that mean decrease like quality of care?
It should mean good quality of care and much more efficiency on our part. There's a lot of inefficiency in hospitals, and a lot of times it's because of cost. So I maybe want to do a certain test. An MRI is a great example. Maybe I want to do an MRI, and I don't have an MRI service 24 hours a day because it's very expensive to have MRI tech there and radiologists there. As a matter of fact, most hospitals don't have radiologists on staff, community-sized hospitals, and even some of the larger ones, they actually use a service called Nighthawk, which is a bunch of radiologists in Australia that are reading all of our images for us. And so those are like ways of using technology to get more efficient. But you're right, there's a lot of things that I just can't send you for a test because you come in at midnight and I want to get this test done at you at 2 a.m., an ultrasound of your leg, let's say, because I'm worried about a DVT. I can't get that until the morning unless I absolutely need to. So there is a lot of efficiency that has to come out for those kinds of units. Yeah. Anything else? Okay, so should we answer some of these up here?
Well, and I think those were kind of the issues that came from the movie. I know some of the questions that came through our discussion in advance.
Yeah.
Discussion. So people were curious, what's the most common thing that you see in the ER, like patients coming in with conditions or injuries or?
We see actually a lot of chest pain. We happen to be a pretty good cardiac center, so we do see a lot of chest pain and a lot of cough and cold, kind of flu this time of year. Those are, and a fair amount of trip fall. I felt a lot more fall off the bikes here than in New Jersey because cycling's a lot bigger here. So we probably get at least one cyclist a week with some sort of road rash or something like that. So we shouldn't see it. Back east right now, what you'll see is, because they're having their big snowstorm, you'll have tomorrow morning people will come in with fingers half on after they reached into the snowblower while it was still running. You're supposed to turn that off. Yeah, so kind of some seasonal stuff. You get a lot of chest pains with people coming in after shoveling snow and stuff. Yeah. So.
And a question you probably get a lot as someone who works in an ER is, what's the most kind of interesting thing that you've seen?
I've had
you
some.
Can tell.
Yeah, I can tell the story. I'll tell the story. This was interesting. It's a little gross, so you guys are okay with that. So we had a young man who was an adult, technically, come in with a lot of abdominal pain, and it wasn't kind of adding up, and nothing was really helping. So we decided we had to do a CAT scan of his abdomen, which we did, and then the results came back. And back in the day, they kind of just like scribbled the results on a piece of paper and faxed them to us, and it was like there was some thing in his colon is lower. And it looks as though it's a cucumber based on this, and I think the radiologist wrote, based on the seed, the way the seed pattern was. And we were like, alrighty then, that's very interesting. Because meanwhile, right, what did the patient not tell us? By the way, I have a cucumber lodged in my rectum. They didn't mention that part. And so that whole case was really interesting, because then his parents come in, and he's an adult, and they're demanding, and meanwhile they've told us it's kind of too far up now, he's got to go to surgery because we have to get it out that way, there's no getting it out any other way. And the parents are like demanding, why is my son going to surgery? You have to tell me. And we're like, and he's saying, no, you can't say anything. Yeah, so I don't know whatever happened if he ever did tell his parents, but, and then definitely I've gotten a few things like, oh, I didn't get that STD from the toilet seat. No, that wasn't from the toilet seat at all. Actually, you probably want to go talk to the person you've been with, because that's what's going on there. Yeah.